So thanks everyone. I'll welcome everyone this morning. Thank you for being here, and we're excited to debate this topic of optimal medical therapy alone versus optimal medical therapy plus PCI for stable coronary artery disease, the million-dollar question, literally. It's probably obvious how we ended up getting selected, Dr. Pfau and I, for our different opposing sides. But I think you'll find that we're probably share a lot in common in our viewpoints. With that said, let me start by presenting the case, and then Krishna is going to take the side of optimal medical therapy alone, and Pfau is going to take the side of optimal medical therapy with PCI. And then a little bit different from the prior debates, Dr. Pfau and I felt like we should probably more try to engage in a discussion rather than reiterate what these amazing fellows have presented, since they will have done a deep dive into the literature. So we hope to maybe facilitate more of a discussion and then potentially bring in more context to the different sides in the second part of the talk. Okay, so this is a patient of mine, actually. He's 44 years old, and his past medical history is significant for dyslipidemia as well as premature coronary artery disease. He came to me after he had already had PCI to the prox RCA at an outside hospital in 2017 for what seemed to be stable angina. He was an avid cyclist at the time and described severe chest pain and jaw pain at peak intensity. And following the first PCI, he had no further symptoms. He then sort of had spotty follow-up in between and re-presented to the emergency department with recurrent exertional chest and jaw pain that was reminiscent of the prior symptoms that he had been having. In the interim, from his first PCI until his presentation in the emergency department, he had stopped cycling. And over the last month, he was getting back into it and trying to get back into shape. So the morning of admission, he had some chest pain, which got worse with cycling. Again, it was to his chest and jaw, pressure-like in nature, and he called his PCP who instructed him to come to the ED. During the last year, he has grumbled about being on medications. He voices his desire to be on the least amount of medications possible, as he is concerned that the medications are, quote, toxic. However, he has been adherent to his current medications, which include aspirin, a moderate intensity statin, as well as beta blocker. His physical exam is notable for a blood pressure that's on the lower side, 100 to 110 over 60, heart rate of 70. Otherwise normal exam. His troponins are negative, ECG is non-ischemic, and his total cholesterol is not terrible, but probably not well optimized for this patient. Total cholesterol 150, HDL 35, LDL of 99, and a resting echocardiogram shows a normal systolic function. The cath results from the outside hospital had shown a normal left main, no LAD disease. He had a 70% mid-circ lesion, and again, 99% vessel stenosis with diffuse distal disease prior to the crux.
Erica, why did he stop cycling after the PCI?
He's kind of this, a little more than a weekend warrior, but he's a pretty intense guy. And when he goes at something, he goes really hard, and then he kind of withdraws from activity. So no real explanation other than he's busy at work. He has a pretty stressful job and just sort of got out of it. He didn't express like concern or fear about cycling, and in fact sought no advice when he came back and to resume biking. So he was admitted to our chest pain center, and I happened to be on call, so I actually saw him there. He went 8 minutes on the treadmill. I would say not terrific for a 44-year-old guy who's supposed to be an avid cyclist, even if he was out of shape. Developed some jaw pain, but no ischemic changes, ECG changes. And then perfusion imaging showed a medium-sized, moderate intensity, reversible defect in the mid to apical lateral wall. And the CT performed for attenuation correction showed moderate calcification in the LAD, circ, and a stent in the RCA. And there was some hypokinesis in the lateral wall. I'll again just refer back to his cath reports that we had from 2017 showing that moderate, at least moderate left circ lesion, the RCA that was stented, and the circ that was left alone. Okay. Does anyone want to start us off?
All right, good morning, everyone. Can everyone hear me? No, I'm gonna use the.
Oh, you're good.
Yeah. Okay. All right, so I'm going to be making the case for optimal medical therapy in stable CAD. So I want to start off just kind of dissecting a couple components of the case, kind of highlighting what I think is some important features, because I think this is a case where it could potentially go either way. So starting off looking at his age, this is obviously a very important factor. If he was someone who was, let's say, 85, this would potentially be a different discussion. Again, the symptoms seem to be stable exertional symptoms. So again, if this was someone that was, let's say, had more unstable symptoms or concerning for ACS, this would again be a different discussion. In terms of his vital signs, so his blood pressure is pretty well controlled on the softer side even. His heart rate is okay, but maybe has some room to improve. He's on some medical therapy. He's on an aspirin, statin, beta blocker, but again, there's room to potentially up-titrate that. His LDL is 99, which again is decent, but maybe not quite at goal. And his perfusion imaging had a medium-sized, moderate intensity defect, so not something that was very high risk, again, not something that was very low risk, so kind of in the middle there. And we already know from his prior cath report that he has some circ disease. So more than likely, this is probably the circ disease. And he's got a normal echo, normal EF. So the way that I'm going to be kind of framing my argument is looking at, what are the adverse effects of CAD and how do we sort of go about treating that? And there's kind of three things that I'm going to be focusing on. So mortality or rate of death, and when we're comparing therapies, is there an improvement in one versus the other in terms of rate of death? Looking at the rate of subsequent MIs. And then lastly, symptoms and control of anginal symptoms. So I'm going to start off talking about the COURAGE trial. So before COURAGE, there actually were several studies that looked at this question of PCI and OMT versus OMT alone, but a lot of them were fairly small studies, small numbers. A few of them also didn't actually use stents, they used balloon angioplasty. So COURAGE was kind of one of the first large trials that looked at PCI with stenting with medical therapy versus just medical therapy alone. So this was a prospective, multi-centered randomized trial in the early 2000s. And again, it was comparing OMT alone versus OMT with PCI in treatment of stable coronary disease. It was a fairly large trial. There were over 2,000 patients with more than 1,000 in each arm. And the primary outcome that they looked at was composite of death from any cause and non-fatal MI. And then also had secondary outcomes looking at those specific factors and a few other things as well. And the patients were followed up for a median time of about 4.6 years, almost 5 years. They included patients that had stenosis of at least 70% in one proximal coronary artery that either had a history of PCI CABG or chronic symptoms, and had objective evidence of ischemia, whether there were new EKG changes or ischemia on stress testing, including nuclear stress testing. or there were patients that had disease more than 80% with angina without, they didn't necessarily have to have provocative testing. They excluded patients that were persistent CCS class 4 angina. And just to kind of refresh everyone on CCS class, so it kind of goes from a score of 1 to 4, 4 being angina at rest, 1 being angina with very strenuous activity, and 2 and 3 being angina with moderate and mild activity. They excluded patients with markedly positive stress tests, if in refractory heart failure or shock, if they had a very low EF, if they had recent revascularization or their anatomy was not suitable to PCI, or if this was in-stent restenosis, and any other limiting comorbidity. So I want to focus a little bit on what actual optimal medical therapy was done during the trial, because it was pretty comprehensive and pretty extensive. So they had a lot of risk factor modification. They had cessation counseling for smoking. They focused on dietary changes as well and had counseling on reducing dietary cholesterol and things like that. They had a pretty aggressive goal for getting the LDL down to 60 to 85, and they used simvastatin plus minus ezetimibe for that. And once they got to that goal, they also tried to get the HDL up more than 40, triglycerides less than 150, mainly using niacin. They had patients engage in at least moderate intensity physical exercise, about 5 times per week, with a goal of also getting their BMI less than 25. And they had a blood pressure goal as well, less than 130 over 85 or 130 over 80 if you're diabetic, and control of your A1C less than 7. So pretty comprehensive in terms of their medical therapy. This is just a table taken from the paper that looks at both groups, looking at kind of their baseline values and then following them up for 5 years. We can see that in terms with respect to aspirin, statin, beta blocker, there's a fairly high amount in terms of percentage of use. There's about 2/3 of patient use in terms of ACE inhibitors, nitrates. Some of those petered off a little bit with the follow-up, but those 3 main kind of stayed at fairly the same percentage throughout the trial. So these were the results of COURAGE. So looking at the primary outcome, so survival free of death from any cause and MI, when we look at follow-up here out to almost 7 years, no difference between medical therapy alone and versus PCI with medical therapy. When we look at overall survival, again, no difference when you follow out. When you look at hospitalizations for ACS or survival free of MI, again, no difference between the 2 groups at follow-up. And they also looked at symptoms, so patients that were free of angina in this time period as well. And yes, initially, when you look at kind of the 1-year follow-up, there was a statistically significant amount of patients that were more free of angina in the PCI plus OMT group versus the OMT group alone. But by about 5 years, the percentages kind of equalized. And so the results that I kind of take away from COURAGE is that when you look at it as an initial management strategy for stable CAD, PCI plus OMT did not reduce the primary composite endpoint of death and non-fatal MI, despite these patients having objective evidence of ischemia and extensive coronary disease. And while the degree of freedom from angina was statistically significantly higher in the PCI group initially, there was also improvement in the medical group. And as when we look out to kind of 5 years, those percentages kind of end up being about the same. And I didn't show this, but the secondary outcomes also showed no statistically significant difference. I'm going to talk a little bit about the FAME2 trial. My opponents are surely going to be talking about this more in detail. So I just wanted to highlight a couple features of the trial and a couple kind of criticisms of it. So as you all know, this was an FFR-guided PCI with drug-eluting stent with OMT versus OMT alone, looking at reducing the rate of death, MI, or urgent revascularization among patients with stable ischemic heart disease. And their main finding was that there was a significantly lower rate of those composite findings in the PCI group versus 4.3% versus 12.7% in the medical therapy group. And the trial was actually stopped early for this reason at about a year. However, what I want to highlight here is that the main thing driving that difference was urgent revascularization. So when you look at just death from any cause or MI, there was no difference. What was really driving that change was urgent revascularization. And so what is urgent revascularization, right? So the study was unblinded in the sense that the patients had FFR done, and these were patients that were known to have hemodynamically significant lesions. And so urgent was defined here as basically patients that had chest pain with or without EKG changes, with or without positive biomarkers that were needed to get revascularization. And so urgent is a little bit potentially in the eyes of the beholder here, because more than 50% of the patients that had chest pain afterwards did not have EKG changes, did not have biomarker changes. So I think it just highlights that there may be potential bias in this group of patients, because these people already have known hemodynamically significant anatomy, and if you already know that and someone's coming with chest pain, you may potentially be more apt to go the PCI route or for revascularization afterwards. The other thing was that the follow-up period was short. Unfortunately, the trial was stopped after about a year. And so certain other potential complications related to PCI, such as restenosis, may not have had full time to emerge, and that may potentially affect the data. And then there was also a little bit less in terms of lifestyle modification in FAME2 versus COURAGE. There was some smoking cessation and some diabetes management in FAME2, but they didn't do anything in terms of physical activity or dietary counseling and things like that. So that may also play a role. And when you look at the 5-year follow-up data of FAME2 as well, again, the rates and causes of death did not differ significantly between the two groups. And we can see that in this chart here, out to 5 years of follow-up, no significant difference. In terms of angina score, again, yes, there was an initial difference, but when you look out at 5 years between the groups, there was no significant difference. I didn't put the chart in here, but if you look at MI, the paper talks about that there was potentially less MI in the PCI group. However, when you look at the hazard ratio confidence interval, it hits 1 exactly. So could go either way. And then my opponents will argue, well, there was a fairly high crossover rate to PCI afterwards, about 50%. But again, this brings that question of bias. When you know that patients have disease, would you potentially be more apt to revascularize them afterwards? And so I want to just kind of bring back the original kind of 3 points that I brought up to frame my argument, to just kind of summarize a little bit of the data. Again, talking about death rates, MI rates, and angina symptoms. So COURAGE and FAME both showed that in stable CAD, PCI does not reduce mortality, and this was shown in follow-up data as well. COURAGE also showed that there was no difference in MI. FAME also showed that early on there was no difference, with maybe a suggestion of benefit later on, maybe. And yes, both of them did show that there was a benefit in terms of angina symptoms, though that may not necessarily peter out to long-term follow-up. So the question that sort of comes up here is, well, the data shows that there's really no difference in mortality, no difference really in MI, so is perhaps the use of PCI in this setting for symptom relief? And I would argue that perhaps not, because, well, symptoms are subjective, and so patients that are followed with symptoms in the trial versus someone that's in your office may potentially be different, and simply having a randomized trial may not necessarily mitigate that. And this is where a very interesting trial comes up, which is the ORBITED trial, because this was a trial that basically was a blinded study with basically looking at a placebo sham procedure compared to PCI with OMT. So this took place in the UK in recent years. It was blinded, multi-center prospective trial. And again, looking at PCI versus a placebo procedure for angina relief in patients that were optimized on medical therapy. Yes, it was a bit of a small trial. There were only 200 patients, about 100 in each arm. And their primary endpoint was looking at kind of what I call objective kind of symptom data. So looking at difference in exercise time increment between the groups. But they also had secondary endpoints where they looked at a few other, again, kind of objective things like Duke treadmill score, change in wall motion score index with dobutamine, but also subjective things like angina frequency, angina symptoms, quality of life. They included patients with a wide range of years with angina equivalent symptoms. And this was really looking at single vessel disease. So lesion more than 70% in a single vessel that was appropriate for PCI. They excluded patients that had disease in other non-target vessels, as well as patients that obviously had ACS, prior CABG, left main disease, could not get a stent, CTO lesions, valvular disease, severe LV systolic impairment, significant pulmonary hypertension, and if they had a low life expectancy. And these are patients with drug-eluting stents. So the way that the trial was designed, so they had patients where they took kind of their initial kind of baseline data, and they did the 6-week medical optimization phase, which I'm going to talk about next. And then they, again, collected data, did some of their exercise testing and things like that. And then basically had patients undergo this blinded procedure. So first, patients had invasive hemodynamic assessment with FFR, IFR, and then patients were randomized to either get PCI for those lesions or sham procedure. So if you were in the PCI group, you got PCI. If you were in the placebo group, you basically were sedated for like 15 minutes and had some music playing and things like that. So it was a sham procedure. And then these patients were blinded and followed up for 6 weeks, and then again had their testing repeated, including exercise and all the other factors that I mentioned. This is just looking at what the actual medical therapy was in this trial. So the core kind of group of medications, everybody was on dual antiplatelets, and then statin as well as ACE or ARB. And we can see that there's this is at the post-medical optimization phase, so that 6 weeks before they were randomized into the two placebo or PCI. And we see fairly high rates of use of medication. And then they were also on at least 2 of the following anginal medications as well. And if you, I didn't put these numbers in, but if you look at the numbers even post-randomization after their procedures in that final 6-week follow-up, the percentages were about the same. So patients were on therapy throughout at a pretty good rate. This is a figure taken from the paper itself, just to give you a sense of what these lesions kind of look like. And we can see these are, when you look at it angiographically, these are significant lesions. From experience, I would say that if we had a patient that came in with chest pain, had a positive stress test, and gets a cath and has a lesion like this, more than likely we would probably stent it. But is that the right thing to do? And so this is looking at the primary outcome from the trial. So this was looking at exercise time. So we have PCI on the left here, placebo group on the right here. And this is looking at exercise time in seconds, pre-randomization. So this was after optimization of medical therapy, but before the 2 procedures. And then looking at follow-up after 6 weeks. And we see that in the PCI group, there was a benefit of increasing their exercise time by 28.3 seconds. And in the placebo group, we saw that they improved by a little under 12 seconds. And so the incremental difference between the 2 groups was 16.6 seconds, which statistically was not significant. And this is a lot of data, but what I really want to highlight is looking at almost all the secondary outcomes as well, such as time to ST depression zone exercising, physical limitations, angina frequency, quality of life. Looking at just about all the secondary outcomes, none of them hit statistical significance. The only one that did hit statistical significance was the dobutamine wall motion score index. But again, it was it didn't seem like a very significant in the sense that we don't know what those changes really mean. It was only 6 weeks of follow-up, so I don't know what to do with that data. But most of the secondary outcomes did not show statistical significance. And then this is just showing that PCI is also not benign. Yes, the numbers are small, but There were patients that had major bleeding requiring transfusion relating to dual antiplatelet therapy. There were patients that in the sham group did have to go PCI because of pressure wire related complications. Patients had issues related to sedation. So it's not a totally benign procedure, so we have to keep these things in mind. So the conclusions that taking away from Orbita is that PCI compared to a placebo procedure did not improve exercise time beyond that effect. Even though patients were having ischemic symptoms, there was significant choriostenosis angiographically, anatomically, as well as hemodynamically. And even when there was objective improvement or relief of those stenoses, so the mean FFR before was 0.69 and post-PCI was 0.9, even with relief of that, there was no difference. Now, yes, there are some shortcomings to the trial. It was small. There was a short follow-up period, and there have been arguments that, well, it's not very real world, especially when it comes to the medical therapy, because patients were being called about 3 times a week or so, which is not something we can necessarily do in the real world. And then after the trial, there was a very high amount of crossover, though there's no significant follow-up data for that in terms of why that was. The study investigators basically said that after the 6 weeks, patients were unblinded and then could make a decision with their doctors on what to do next, basically. So what their actual reasons were for crossover, not quite known. But I think it's a very provocative trial because that last factor that in what I was talking about in terms of symptoms, I think it still brings into question whether there is truly symptom benefit, either subjectively or objectively. And I think on a bigger picture level, it just kind of makes us think about cardiovascular disease as more complicated than just a pipe that needs to be clean. It's not as simple as just there is a stenosis which leads to ischemia, which leads to symptoms, and if you fix one, it takes care of the process. There's a more complicated underlying process going on. I'll just mention that there is an interesting trial that's going to be coming out called the ischemia trial that I think our patient kind of fits into. This is someone, these are patients that are moderate to severe ischemia on stress testing that will then get coronary CTAs to rule out left main or non-obstructive disease and then randomize in a blinded fashion to cath versus no cath. So this will be an interesting trial to follow. So I will leave you with some final conclusions. So when we look at Courage and Fame, there was no difference with respect to death and MI. When we look at Orbita, there is perhaps no real improvement in anginal symptoms either, which brings up this idea of placebo effect and how much that is playing a role as well. And so I submit to you that first-line therapy should be optimal medical therapy alone over PCI. Again, a couple last points, just kind of overall thinking. I think that some of these latest trials, again, bring into question some of our dichotomous thinking of stable CAD. I think it's important that we have biases that can affect the way we treat patients, and that we need to think about the patient as a whole, and whether patients have different thresholds. So 70%, does that cause symptoms for everyone? Maybe, maybe not. So we need to kind of think about what the threshold is per person rather than a dichotomous variable, more of a continuous variable. Could there be differences in plaque morphology? These stenotic lesions might be stable and may not result in significant issues, whereas the unstable ones without significant stenosis may be the ones that are causing problems. And then finally, I think it's important to just talk about in terms of the Orbita trial, what was novel were these kind of placebo-controlled interventional trials. When we look at a lot of the medication trials, they're placebo-controlled, but not necessarily with the interventional trials. So I think that there is more need for that to potentially parse out this placebo effect and things like that. And then last thing, again, kind of in our kind of current era of practice, thinking about shared decision-making. And coming back to our patient, is it someone that is going to take pills or pills plus stents? Because those will be slightly different. If you get a stent, you'll be on dual antiplatelet. How will that affect his quality of life? What are his goals? If he's going to be biking and he may potentially have injuries or scrapes or falls, will being on dual antiplatelets potentially affect that? or his blood pressure is on the lower side to begin with, will anti-anginal medicine potentially, make it difficult for him to exercise? So at the end of the day, we need to bring it back to the patient and make a shared decision. So my final thoughts, speaking of kind of current era and kind of current events, you may have all recently heard the whole college admissions scandal with Felicity Huffman, her husband, William H. Macy, Lori Loughlin, where they bribed and lied to basically admit students to top colleges. And as my opponents take the stage, I will note that there is a striking resemblance of them to these celebrities. And so I will caution you that they may bribe you with data, they may lie to you about data to admit their patients to the cath lab. So thank you, Dr. Spatz, Dr. Pfau, CEO, and Dr. Ahmad. These are my references.
I appreciate that.
Oh.
I was kind of expecting that.
Hey everyone, let's work this one out. Oops. Thank you all for being here. Thanks Krishna and Dr. Spatz. Now it's Dr. Pfau, my turn. We'll try to rush a little bit to get to it. But we're going to talk about optimal medical therapy plus PCI in the treatment of stable CAD. And when this topic was first assigned to me, I was really excited. I was so excited that I actually asked Dr. Pfau to be my mentor over 6 months ago. On a Friday night, I texted him and I'm like, you have to be my mentor. And the excitement comes from the fact that many of you guys know I'm going to do interventional cardiology. If Dr. Brennan will have me, I don't know what. And part of my excitement goes that not only want to achieve as many technical skills as I can achieve, I also want to achieve all the knowledge I could possibly get. Because at the end of the day, I want to know all the strengths and weaknesses of these trials. So when the time comes in the near future that I can sit down with my patient, I can provide him all the information or her all the information so we can all make the better decision together. With further ado, these trials that we'll be discussing, when I talk about courage from now on, I'll be talking about courage, the trial. I won't be talking courage as a strength in the face of pain. I'm so glad that you put that picture because I do find you courageous. Look at his face in the light of pain. He's pretty courageous, I'll say. But let's talk about the caveats of courage itself. It had a high rate of exclusion patients. Over 35,000 patients were screened, and less than 7% were ultimately included, which inevitably raises the concern whether there was a selection bias or not. Moreover, 85% of these patients were male and 86% were white. So the external validity of this trial is also a bit limited. And interestingly enough, 15% of patients that actually met inclusion and exclusion criteria were not included because their physicians didn't want them to be in the trial. And that speaks a bit of why these trials have such a hard time enrolling patients, and mainly is because cardiologists don't want to enroll their patients with a tight proximal LAD or a large severe area of ischemia. And ultimately, that carries a lower risk population. The other caveat of courage is that it had an intention to treat analysis, which statistically speaking is what we should do. But let's keep in mind that 33% of these patients in the OMT Alone group cross over and receive a PCI before the end of the study. And small percentage, 4% of the PCI group didn't get a PCI. But altogether, 40% of these patients either cross over to the other arm or didn't get the intended treatment. And some will argue that medical therapy back in the courage era, early 2000s, wasn't the best. However, it wasn't bad either. The average systolic blood pressure was 122, the average systolic was 70, the LDL was 72. So it was a pretty good medical therapy. Let's go with the technical issues of the PCI group, however. The stents were bare metal, which is suboptimal. We don't use them anymore almost for stable CAD. 15% of the lesions were balloon angioplasty alone. And the investigators didn't report the duration of that, which we know it's key for the patency of the stents. I'm going to take a few minutes to talk about this topic. Patients were not stratified by ischemic burden. And there was a small sub-study in Courage that was about 300 patients that did got a SPECT before the treatment and after the treatment. And 40% of patients had either no or less than 5% ischemia. So it's kind of hard to find or understand how patients with no ischemia or minimal ischemia will benefit from a PCI procedure. And only a third of these patients had moderate to severe ischemia, which is defined as 10% or more of ischemic myocardium. And this 10% of more ischemic myocardium comes from this trial published in Circulation in the early 2000s. You guys can see on the left side here, people, medical therapy is in blue, revascularization is in red. People with no ischemia or minimal ischemia did better with medical therapy, obviously. However, these two crossover at around 10% or so, at which revascularization begins to have a role, in this case, in survival. So which therapy is better at reducing ischemia? Again, this is still Courage. This is the sub-study group. And this is PCI on the right side and medical therapy on the left side. PCI did better at reducing ischemia compared to OMT. And not only did it better, they also found that the patients with baseline moderate to severe ischemia were the ones that benefited the most from a PCI procedure. So now patients got randomized, they got their treatment assignment, whether it was medical therapy alone or medical therapy plus PCI. And this is the event-free survival curves for residual ischemia. You guys can see in blue, when you have zero ischemia, the event rate is 0. And the more residual ischemia you have, the higher your event rate is. They almost had almost 40% event rates. And this is another way of looking at this. The higher the ischemia, the higher the event rate. And unfortunately, there was only 300 patients. So ultimately, when they adjusted all these variables, the P was not significant, but it's something to take into account. And let's talk about medication disutility or inconvenience and patient adherence. Most of us here are in the medical field, all of us, otherwise it will be weird that you guys sit here. But so if someone tells you, you have to take some medications to decrease your cardiovascular risk and a few others to make you feel better and perhaps even spare you a procedure, at least for me, it will be a no-brainer, right? Except that's not the reality. Our patients don't like taking medications. And although Courage and all these trials have a very high percentage of adherence rate, 93% in Courage were still taking their statins after 5 years, which is a very high number and doesn't reflect routine clinical practice. This is a meta-analysis of 20 patients and included over 370,000 patients. It shows that the adherence rate for primary prevention of CAD is only 50%, and the adherence rate for secondary prevention of CAD is only 66%. So this brings the entire disutility adherence issue. Disutility increases with number of pills, right? So higher the number of pills, the more inconvenient it is for the patients, and the less adherent they come. So what if we focus on those medications that are proven to decrease MI and mortality, such as statin, and less on anti-anginals? And this was an interesting fact. I wouldn't take it as, it's not a fact, as an interesting anecdote. A couple of these trials found that patients were actually willing to sacrifice 6 months of their life in order not to take a daily pill. It just speaks of the burden of taking daily medications on our population. So now let's talk about FAME. I'm going to talk about FAME2 specifically. So every time I say FAME, I'll be referring to FAME2. I won't be referring at the state of being known or talked about by many people, especially on account of their notable achievements. Many will say that Dr. Spatz is a rising star. I will agree with those statements. Look at all the news on her feed, and these are just a few of them. And this is Dr. Spatz, and Dr. Ahmad actually tweeted about her. It says, hey, look, it's giant picture of Aunt Spatz, well, Aunt Erica. This is his kid, very excited, taking pictures because Dr. Spatz has like billboards and giant pictures all over New Haven. She's that famous, okay, guys? But I'm not talking about your type of fame, Dr. Spatz. I'll be talking about fame as a trial, okay? One slide for fame one, just to take home point is patients with multivessel CAD, FFR-guided PCI, it's superior than angiographically guided, okay? And with, this is something that FAME2 looked into FFR-guided PCI plus optimal medical therapy versus optimal medical therapy alone. And the primary endpoint was rate of MI, death, and urgent revascularization altogether. And compared to medical therapy, PCI did better. And yes, Krishi, urgent revascularization was the main trigger for this. But there's a couple of layers to this. First of all, the FAME2 investigators calculated that they needed about 800 patients in each treatment arm to power their trial at 84% in order to find a significant difference in all of their outcomes. However, because of these striking findings, the trial was ended up early by a safety committee because the primary endpoint was significantly lower in the PCI group. So ultimately, we ended up with a little bit, 888 patients instead of the 1,600 plus patients that were intended to be included. So the main question comes, do we even have enough patients and enough power to detect any of these differences, especially in death and MI, where the rate of these events are lower, and therefore you need a higher N. And the other issue is that the intention to analysis, again, 51% of the OMT group crossed to PCI. So you don't only have half the patients included, but rather half of your M3 patients actually already cross over to PCI. So this weakens, whether we like it or not, this weakens the statistics towards PCI. And if we actually take a closer look at the secondary endpoint of myocardial infarction, medical therapy is in red, PCI is in blue. If we take a closer look, the first 3 years they overlap, but from year 3 in advance, these two lines steadily start diverging one from the other. And by year 5, medical therapy and PCI has a pretty good distance among each other, and hazard ratio was 0.66. Unfortunately, for my argument, the confidence interval reached 1 and was deemed not significant. But what would have happened if we would have had the 1,600 patients initially, or we would have had longer follow-up period? We want to know. So in urgent revascularizations, let's go over the type of trigger for these urgent revascularizations. It is true, and I hear the Krishna and Dr. Spatz's point that patients not being blinded to their disease, makes them maybe more prone to seek attention. Completely agree. However, 49% of these patients actually require an urgent revascularization for positive biomarkers for a heart attack or for new ischemic EKG changes. Okay, the other 50 plus patients indeed receive urgent revascularization based on clinical features alone, but let's see that the darker green, it's class 4 angina. Class 4 angina means that they're having angina at rest or at minimal activity. Okay, but let's say that the clinical features, it's too of a soft endpoint and you guys don't want included. If we exclude all the clinical feature triggers for urgent revascularization, there's still a statistically significant difference between urgent revascularization trigger in the PCI group by positive biomarkers and ischemic EKG changes versus the medical therapy group. And yes, the initial critique of FAME2 was that the follow-up was too short and issues in the PCI group such as stent restenosis were not going to emerge so early in the trial, so early in the follow-up. But this is the cumulative incidence of any revascularization in the 5 years of COURAGE. And you can see that medical therapy had a higher incidence of revascularization for any cause compared to PCI alone. PCI group, only 14% of patients require another revascularization, either because of another event for worsening symptoms or ISR altogether. So everyone here would like to save a life by starting a medication or implanting a device or putting a stent. We all love to save lives. But sometimes our argument should be making our patients feel better. And this is angina overclass. And PCI is in blue, medical therapy is in orange, and this is over time. And although both therapies were very good at reducing angina, PCI was better. And yes, at 5 years, there was not a statistically significant difference between these two groups, but this is too simplistic or too easy to say when by this time, 51% of your patients already got a PCI, right? And let's talk about FAME2 registry for a little bit. So how FAME2 included patients is basically every patient with stable CAD that had 1, 2, or 3 vessel planned drug-eluting stent were doing FFR. Those with FFR positive were, randomized, that's what we just talked about. But those patients with angiographically significant lesions and symptoms that were planned for a PCI but had a negative FFR, those patients were offered the best medical therapy, and those were the FAME2 registry. And if we take a closer look, registry is in green and PCI is in blue. You might not tell a difference because they're literally one overlapping the other, meaning patients in the FAME2 registry did excellent with optimal medical therapy. And that raises the concern, how many of ORBITA patients or COURAGE patients that we didn't have any hemodynamic or functional data were somehow like patients in the registry, angiographically significant lesions and symptoms. You cannot argue that PCI in these registry patients will do anything good for them. So why FAME2 differ from prior studies? First, the enrollment was based on functional hemodynamic data. 25% of these patients that were considered for FAME2 were not included because they had FFR negative lesions. On the other side, COURAGE, only a third of them had actually significant moderate to severe ischemia. The PCI group received revascularization mainly on FFR. They used drug-eluting stents, which lowers the repeat number of revascularizations. And these patients were on optimal medical therapy on anti-anginals. And despite this does not preclude the significantly higher number of revascularization. And then the primary endpoint included the need for urgent revascularization, and some can argue again that this is a softer endpoint. But when nearly half of your patients need urgent revascularization from an ACS, this should be considered treatment failure, and this should be included as a primary endpoint. Let's talk about ORBITA now. And I again love that you put ORBITA, but I added a twist. I put you flying through the space and orbiting around Earth, very courageously as well, Krishna. And the caveat of ORBITA is that the number is 200. And this was inferred based on some educated inferences, but inferences after all. And then not only that, it took 4 years for 5 major PCI centers to enroll only 200 patients, which unfortunately raises also the concern if there was selection bias or not, and if 200 patients is even big enough to find any significant difference. For example, the improvement of angina on ORBITA was 52 in the PCI group versus 45 in the medical therapy group, which is kind of similar numbers than COURAGE. However, COURAGE, with their 2,200 patients, found this difference very significant with a p less than 0.001. The second caveat in ORBITA is that the PCI was dictated by angiography, not by FFR. So 30% of patients in the PCI group in ORBITA received PCI despite the fact that their FFR was negative. So again, it is hard to imagine how these 30% of patients in the PCI group that got a stent will benefit when their lesions were not hemodynamically significant. And you pair this with the fact that by the end of medical optimization, 25% of patients had either no angina or minimal angina. When you have such a low level of symptoms, it is difficult, again, to show the incremental benefit of PCI. ORBITA did not include patients with multivessel CAD, and we know the more extensive the ischemic myocardium is, the larger the physiologic benefit from PCI. So it only included single vessel CAD and only included normal LVEF, which ultimately is only 25% of our CAD population. The pre-randomization medical phase was very intense, 1 to 3 calls by a cardiologist per patient per week, and constant monitoring it. So not only that, which is very hard to achieve in the real world, patients were on aspirin, on a second antiplatelet, on a statin, ACE on an ARB, and an average of 3 anti-anginal medications. So we're asking patients, let's say we drop the Plavix, we're asking patients to take 6 medications only for their CAD without accounting for their diabetes, BPH, depression, whatever you guys want to talk about. And we're asking patients to take 6 medications only for their stable CAD lifelong, right? And we don't know if they're going to like it or not. That follow-up was only 6 weeks. We don't know if ultimately they had such a high rate of adherence or not, which leads to ischemia for the past 5 years, and it's been taking $100 million, literally so far, this trial. That's what the cost. It's trying to answer all the unanswered questions by what? By enrolling patients before catheterization. So anatomically high-risk patients are not excluded, which is the common denominator. Patients with high-risk anatomies, and I'm not talking about left main disease, but other high-risk anatomies are being excluded, are not being included in these trials. They're trying to enroll a higher-risk patient, but moderate, with at least moderate ischemia by nuclear study, stress echo, or MRI. And ischemia investigators had a hard time enrolling patients because of these two things. So they had to decrease their sample size from 8,000 to 5,000, and they had to add ETT only as a risk certifier, which some will argue that is less than ideal. They try to minimize crossover, which is easier said than done. They're going to use contemporary stents and physiologically guided PCI, and they're going to try to power it enough. So this is the model. I'm not going to go much over it. The take-home point is basically angioplasty with stenting is a safe and effective way to reduce angina. FFR-guided PCI plus OMT effectively reduces the burden of ischemia, the need for urgent revascularization, and possibly the incidence of MI. OMT in all these trials is very difficult to achieve in the real world. And ultimately, last but not least, intuitively, patients and physicians believe that revascularization is better than medical therapy in their higher risk patients. And that's why these patients with a large severe ischemia or with a tight proximal LAD are not being referred to these studies. Special thank you to Dr. Pfau, Dr. Spatz, Krishi. I'm from Lima, Peru. This is not in Lima, but this is all in Peru, and this is all beautiful and wonderful, and you should all visit. Thank you.